Hello, everyone, and welcome to the Red Kite Room, if you didn't know the name of this room. And thank you very much for being here on a Friday afternoon, which seems to be our optimal time to meet together. So I'd like to begin first by welcoming everyone here today. And may I give a special welcome back to Nick Johnson. It's really good to have you here. Don't worry, you didn't miss too much. We're waiting for you to come back. No pressure, sorry. I need to tell you that filming and photography is allowed, and you can take pictures and use social media. Please, could you turn your mobile phones to vibrate? The meeting is being live streamed, as you can see on the screen here. And there is no fire alarm scheduled for today. But if there is, if the fire alarm sounds, then we go out the fire exit and down to the fire park. Okay. Could I ask the Corporate Services Support Manager to report any apologies for absences?
Thank you, Chair. We received apologies from Dr. James Morrow, Vicky Evans, Ellen Redding, she's been substituted by Ricky Cooper, from Jan Thomas, David McQuaid, Paul Med, Daryl Preston, but is being deputized by Jim Hellett. Thank you.
For that. Right, so we're going to do a roll call, which isn't probably what we do at most meetings, but we thought it would be important here for just to get a sense of the organizations represented. So myself, Susan Van de Ven, and then I will call out your name, and please could you confirm your attendance and also indicate the organization that you're representing. Lynn Ayres.
Thank you. You can hear me. Good. Lynn Ayres, I'm from Peterborough City Council, and I'm the Cabinet Member for Children's Services, Education, Skills, and the University.
Jyoti Atri.
Hello, Jyoti Atri, Director of Public Health, covering Peterborough and Cambridgeshire.
Steve Barnett.
Hello, I'm Steve Barnett, Chairman of North West Anglia NHS Foundation Trust.
Kit Connick.
Hello, I'm Kit Connick. I'm Chief Officer for Strategy and Partnerships with the Integrated Care Board.
Thank you. Jed Curran.
Hello, everybody. I'm Jed Curran, and I'm the non-executive member on the Integrated Care Board.
Thank you. Stuart Francis.
Hello, I'm Stuart Francis, and I'm Chair of Health Watch, Cambridgeshire and Peterborough.
Thanks. Julie Farrow, please.
Hello, I'm Julie Farrow. I'm the CEO of Hunt-Sorum. We're an infrastructure organisation, and I'm the voluntary sector rep on the board.
Mary Alford, I think I see you on the screen there.
Hello, everyone. Very sorry I can't be with you today. I'm Mary Alford. I'm Chair of Cambridgeshire Community Services NHS Trust.
Thanks. Claire Higgins. We had apologies. Richard Howitt.
Good afternoon, everyone. I'm Councillor Richard Howitt, Chair of the Adults and Health Committee here at Cambridgeshire County Council.
Sorry, John Howard.
Hello, everyone. I'm Councillor John Howard here on behalf of Peterborough City Council, and I'm the Cabinet Member for Adult Social Care, Health and Public Health.
Thanks. Nick Johnson.
Good afternoon, Dr. Nick Johnson, so children's doctor at Hinchinbrook Hospital, attending as the Mayor of Cambridgeshire and Peterborough Combined Authority, and finally a very grateful returning to the meeting as a recent user of services of the NHS, and very grateful for that. I would appreciate that being put on record.
Thank you very much, Nick. Louis Camphor.
Good afternoon, Louis Camfer. I'm Deputy Chief Exec of the Integrated Care Board and MD for a Strategic Commissioning Unit.
Neil Modha. Oops. Wonderful, thank you. Mike Moore.
Mike Moore, Chair of Cambridge University Hospitals.
John O'Brien.
Hello, everyone. John O'Brien, Chair of the Integrated Care Board and co-chair of the wider partnership.
Paul Ricketts.
Do you mean Piers Ricketts, Chief Executive at Eastern Academic Health Science Network?
I beg your pardon. Thank you. Elaine Redding. Oh, deputized by Ricky Cooper, right? Okay, thank you. Julie Spence. No. Liz Watts.
Good afternoon, everybody. Liz Watts, Chief Executive of South Cambridgeshire District Council, and here representing all of the districts in Cambridgeshire.
Thanks. John Walwork. So, Jim Hallett, you're here instead, I think.
Good afternoon, everyone. Jim Haylett. I'm the Chief Executive for the Police and Crime Commissioner, Darryl Preston, representing him this afternoon.
Thank you. Is anyone else missed today? Oh, excuse me, yes.
Thank you. Richard Kenny. I'm the Executive Director at the Cambridgeshire and Peterborough Combined Authority.
Thank you very much. Oops. Try again. Thank you. And I should have said at the start that my I'll keep this one, shall I?
I use this one, and then if that one doesn't fit,
Sorry about that. I know we need to press on. I was only going to say my colleagues, John O'Brien and John Howard, and I are co-chairing this meeting, and we've sort of decided to take it in thirds. So you get used to us and we find our feet, and we can get used to nudging each other. Uh-oh. Sorry. Okay. I'll move to the next item. We are being asked to approve the minutes of the Cambridgeshire and Peterborough Health and Wellbeing Board Integrated Partnership on the 20th of December 2022 as an accurate record. If any board member wants to raise a question on the accuracy of the minutes only, can they do so now, please? No, okay, I see no objections, so we'll take that as carried unanimously. And I will sign the minutes. Moving swiftly on to item 3, we're very glad to have a community story here today. This is something that I think we've been wanting to bring to this meeting. Can I please introduce Erin Lilly, South Place Lead, and Bob Brecker, Health Champion, to introduce this item. And I think we have Stuart Francis here as well, offering to chime in if need be. So thank you very much.
Thank you very much for having us. I am Erin Lilly. I am one of the directors in the Cambridgeshire South Care Partnership, as we're now calling our South Place. We partnered with Healthwatch about probably 15 months ago now to take forward some work around how we engage more with the community and the users of our services as we start to design them and look at how we transform them. And as part of that, Healthwatch have recruited 12 health champions, as we've called them in the South, who were supported to develop their basic research techniques and engage with us through 2 projects so far. The first project was looking at people's experiences of accident and emergency services at Addenbrooke's in particular. And there's a report on that on the Healthwatch website for anyone who'd like to look it up. And the second project we asked them to work with us on was around gathering information to help understand health inequalities, not service specific, but generally what were some of the barriers and the challenges for people in accessing the services that they wanted and needed to be able to access. And so really delighted that we've got Bob here today, who is one of our health champions, to share a bit about his experience of being a health champion and also some of what he heard through the research process. Thanks, Bob.
Thank you. Good afternoon, everybody. My name is Bob Brecker. As well as a Healthwatch volunteer, I'm also a full-time carer, and I chair 2 volunteer charities in Cambridgeshire and Peterborough. So I've been involved in both of the projects with Healthwatch, and I think they both worked because we were involved from the very start. Once the Commissioner and Healthwatch agreed principles, we were involved. We got to understand the project, what the Commissioner actually wanted to know. We helped frame the questions. We met with the Commissioner, and once we were then handed over to take it forward. We chose the venues. We organised recruiting people to come along to the venue to talk to us. We hosted, as I said, and I chaired 2 of the focus groups, one in Salisbury and one in Soham. Very different demographic people, but very similar responses. And I've been asked to share some of those responses today. Dentistry, it won't surprise you, came up a lot. There was also poor access to mental health services. Everything seems to wait until there's a crisis. Wouldn't more preventative services be of benefit? Staff are so overworked, they don't have time to listen to the patients. Services are not joined up. Having said that, there is universal support for all NHS staff. There were suggestions about volunteer groups working with the NHS more closely. There were suggestions about NHS equipment not being left at the council tip, and we've all seen it. We've had suggestions about OT and physio services being such a long time. Why aren't private sector getting involved more to help? I think the overall, it was no one's talking to one another. departments aren't talking to one another. You have to repeat your story 50 times to 50 different people. And I think one of the ladies that came to one of the groups, her overriding comment was gaining access to social care from the local authority in a timely manner is an absolute nightmare. It took 26 weeks before we even got to the assessment stage. It was a really, both projects have been really interesting, this one especially, and it was really good to be involved and understand a bit more from the community about what they want. So thank you very much.
And just to sum up, I think, so we've now got a report which is also available on the Healthwatch website. I encourage people to read it if you haven't picked up on it through us talking about it at other meetings. We are trying to share it reasonably widely and make sure that we're taking it back through our individual organisations in the system as well as through the partnerships to look at what we can move forward with in response to the feedback that we've had. A couple of unintended positive impacts, I guess, out of it that I think is also worth sharing. One is that through the training of the health champions, in order for them to work with us on this piece of work, some of them have gained new skills, and in fact we've lost some of them in a positive way because they've gone on to get jobs with those new skills. So I think that's a massive unplanned win out of that piece of work. And the North Care Partnership are now working with Healthwatch to roll it out across the North and take a similar approach. I think we've learned, by no means are we experts yet, but we've learned a lot about how to do some of this engagement with the community work in a way that we weren't doing before, and that's feeding into lots of community engagement approaches, which we'll come back and share another time. But there is, I think we're really growing our confidence in how we do that, and the project's been super positive in that space. Thank you.
Thank you so much. It's great to have sort of real life right here at our meeting, a challenge for everyone. Does anyone wish to ask a question?
Not a question. I'd just like to add a couple of thoughts. First of all, thanks to Erin and Bob. We are very proud of this piece of work, and we do believe that it can be replicated. We learn from each piece of work that we do. Reducing health inequalities is obviously a priority, one of the main priorities of the ICS. And this report, Tackling Health Inequalities, is perhaps a really good sign that Healthwatch is here to help. I recommend the report to you. It's essential reading for all those who are involved in tackling health inequalities, and that is all of us. So I hope you all have a quick look at it. The strength is that it is driven by the volunteers and people like Bob, who've done a great job for us leading these focus groups. So this really is a piece of bottom-up work that we can listen to. Just to summarize, it does speak to the barriers, and there are some good indications how we can break some of those down. Some of those are easy, I think, and some are more difficult, but it is all there for you. And as Erin has said, it's a piece of work, a similar piece of work, will take place in the north of the county as well. And I'd just like to thank everyone who's supported that piece of work. Thank you, Chair.
Wonderful, thank you. I think we have Nick and then Neil. Thanks.
Well, I'll make the promise that I will go away and read the report. So I think, as you say, we all should, I'm sure. Whenever you do these sort of consultation pieces, inevitably there's certain groups that are hard to reach. And perhaps comes as no surprise, speaking with my medical hat on, one group who are routinely unrepresented sometimes with a voice at these meetings are children, anybody under 18, because often they don't know about them, or they don't have an advocate for them. I just would be particularly interested to hear in regard to this report, and I appreciate I haven't read it, how did we target hard to reach groups? And that then means refugees and other similar sort of groups that are difficult thing, but particularly what makes up about 20% of the population, those who are under 18.
Thank you. Sorry, Stuart, could I trouble you to press the button again? Thanks. No, no problem. Thank you, Nick. And over to you, Neil.
Oh yeah, just to say, I guess at the moment it's quite sad to hear how much people are being let down by services at the moment. But I guess what's quite positive over the last few years is we've been increasing the amount of connectors out there. So mental health connectors, social care connectors, and things like that. And although it's difficult accepting that we need those kind of roles, it's really helpful, I hope, for patients to know that now there's a growing importance on making sure that people don't feel let down by services and making sure that they can attend and that services are more accessible for them. So just a comment really building on the feedback that you've received.
Thank you for that. Oh, Stuart.
Yeah, in response, all I would say is good point, Nick. And we absolutely take that on board. When you do look at the report, you will see that we've spoken to a lot of people who previously didn't have a voice. The homeless, the Gypsy Roma communities, they are all in there, and you'll see that that comes out loud and clear.
Hey, they're coming thick and fast now. I think Mary, Alfred, and then I see Lynn, Julie, and Liz. Thank you.
Thanks, Susan, and thanks to Erin and Bob for putting over some really powerful points very concisely, but you know, the really had an impact, and I think there's a lot for us all to reflect on from what you've said. I wanted to pull out the point on dentistry, which, you know, as we know, is a national issue, and one as you know, going to Nick's point, obviously particularly affects children. And the specialist commissioning, I think, is coming to the ICS in April, if I've got that right. And I just really wondered what the thoughts are in terms of how we're going to improve dentistry within our patch.
For a 5-second answer on that small subject.
I'll keep it to the 5 seconds, but Mary's absolutely right. Obviously, that comes to ICBs from April. We had a long discussion about this at the Integrated Care Board a couple of weeks ago. And I guess the challenge is, given some of the, as Mary says, a national issue and some of the constraints, particularly around the national contract and those issues, how do we try and bring about as safe and effective landing as possible, but then look as a partnership to try and build the sort of improvement what we want to see over a period of time? And I think most people around that board table recognise that's quite a tall challenge and not straightforward. But as Mary says, there are some particular issues about children's dentistry and links to our wider agenda around inequalities and the like. So yes, it's sort of, we've got to try and seize that opportunity, but you know, there's quite a few challenges to work through.
Thank you, John. And I might just add that the Cambridgeshire Health Scrutiny Committee has been chatting with our ICS colleagues about bringing this matter to our members to have an early look at. Let's see, was it Lynn?
That's me. Okay, thank you. Yes, still on children, because that's my subject too. We have a children in care council at Peterborough, and possibly there is one at Cambridgeshire too, I don't know. But the fact is, we've had terrible trouble getting our children seen by a dentist at all, by an NHS dentist. And we end up having to either pay for it from the local authority, get somebody else to pay for it with a private dentist. And so in terms of what's going on and how the children see it themselves, can I suggest that the Children in Care Council might be a good place to go to hear the voice of the child across the county? Because they are, as I say, we all have bad teeth as children, I'm sure. I certainly did. So thank you.
Thank you, Lynn. I think we'll just complete the questions. And Julie, I think you're next.
Thank you. Mine was twofold, really. So thanks very much to Erin and Bob. I've seen the presentation before at a previous group, but I just wanted to sort of pull a few things together revolving around how we engage with our communities and how we engage with young people. As Lynn rightly said, there are several organised groups that actually listen to young people right now. We've got quite a lot of them in Cambridgeshire and Peterborough. They do that very successfully, and it's just about how do we link those together very effectively. And certainly the voluntary sector works really closely with Health Watch, and therefore just making sure that actually those things are connected, I think would be really useful. And I think this is a fabulous piece of work, and that we should actually do more of this. And I think Health Watch as an organisation are ideally placed to do this because they're independent and they can actually ask the right questions, and similar to the voluntary sector, are not perceived to actually have already made their minds up revolving around where we want things to go. And so they are totally independent of it. So I just want to say thank you very much to Bob and to Erin for it. I think it's a great piece of work, and we just need to connect other things to it now, so we've got a much broader picture.
Thank you. And Liz.
Thank you. Thank you, Chair, and thank you, Bob, for a great piece of work. Please thank your other volunteers. I'll certainly commit to taking this into all of the district councils in Cambridgeshire. And I think it's really interesting for us that this talks a bit about the health system not being that joined up. But I think the problem is probably more complex than that, because the entire system, and by that I mean public service, is not joined up. So when you talk about telling 50 people the same thing 50 times, that's not just health people, that's my colleagues in benefits and council tax and housing. So I think there's a bigger challenge here, which it makes it harder, but it's one that we certainly, are fully committed to addressing. It's not just about health.
Thank you. I wanted to ask if we could have the report circulated, and certainly in the minutes to refer to. I know Sandy Smith from Health Watch is retiring, and I was hoping she'd be here now, but I would have said, the work that you've done shows what Health Watch is all about. And it is certainly the glue here for the Health and Wellbeing Board and the Integrated Care Partnership. And I know as a local councillor, Health Watch knows my individual residents who are struggling to navigate their way through the system that Liz just alluded to. And, without that basic advocacy, I think we would be really struggling. So I wanted to thank you very much for that, and to wish Sandy all the best, and to thank her for her work over such a long time with Health Watch. And hopefully we'll see her a little bit later to say that in person. Thank you. Okay, I guess we'll move on to the next item, and you can track in the rest of our discussions whether you see meaning being brought to some of the things you've raised with us today. So we have item 4, and before handing over to Jyoti, I just thought this would be a moment just to say that, and more for anybody who's following the meeting than who's here today, perhaps, but we are enormous organizations, and the work that we have to do when we come together, much of it is obligatory. We have to fulfill certain requirements, and we have to meet in person to do those things. And we also need a chance to reflect and to question and to take some time to consider what we're trying to do and where we're going. So we have had we've sort of fallen into a good pattern of meeting informally between these formal meetings to kind of take stock and look in more depth that we don't have time for when we meet formally. So we have actually a really good session at the beginning of the year to look at how the priorities are evolving and to sort of feed into them, really. And I think what we're seeing today reflects that discussion. Right, over to you, Jyoti.
Thank you. I'm not going to talk for too long because I really want to allow more time for the priority discussion and for you all to ask questions. Just to say that the board has previously seen drafts of the 4 priorities, the strategic content of those. They're here today again for sign off, and then they will be kind of set in stone as our strategic content for the 4 priorities. What you're also seeing today for the first time is the action plans associated with those 4 priorities. And they're a starting point, I'd say. We fully expect them to develop further as we get some of our products come to fruition, for example, evidence reviews or behavioural insights, which will further inform the development of our action plans. And as we further engage with our communities and system partners, that will also add to the action planning. So they're a starting point. I think they're fairly well developed, and I think you'll see when they're presented that there's been good system engagement in the development so far. They've been led and owned by the SROs, and many of them are here today to talk to the content. So I'll just let people know which order we're going to go in so they're prepared. We're going to start with children, and then environments for healthy living, and then addressing poverty, housing, and then employment, and then finally mental health. So if I could hand over to Matthew and John for the first action plan. Thank you.
Great, thank you. Good afternoon, everyone. I'm Jonathan Lewis. I'm Director of Education for Cambridgeshire and Peterborough Local Authorities.
Hi, and I'm Matthew Wynn. I'm Chief Executive of Cambridgeshire Community Service and NHS Trust.
Thanks for inviting us along today. We wanted to talk to you about the first priority, which was around children's. I think if we look at education, the purpose of education is to get children and young people ready for adulthood. What we've learned through the pandemic is that being ready for adulthood is a multi-agency response, working together, sharing that goals and aspirations, and putting in the right support has a long-term benefit on society. So what you're seeing through the plan that we presented today is the I think really positive first steps around joining up agendas and making sure that the work we do ensures that children come into education ready to learn. They are well supported through their education, and when they exit, they effectively transition into adulthood. There are some direct benefits of a good education on health outcomes, and we've tried to develop these in the report. So those that achieve higher grades have better measures around health, income, and life expectancy. The extension of schooling beyond statutory school age does have a direct link to mortality, risk of heart disease and diabetes, and a reduction in depression and anxiety. So what we try to do through the plan is really capture the actions that we can take, both when a child is in the very earliest stages, up to the age of 2, as they start their formal education. Obviously delighted to hear from the Chancellor about extending early years education, which will give us the platform to reach out to more families early and support those needs. But obviously then working with those that are less able at the end of their education to make sure that they transition through into adulthood and are supported into employment, education and training. So we have defined in our strategy three measures: that the proportion of children with a good level of development increases, so the point at the start of their education in primary school, that we reduce the number of young people not in employment, education and training. And more importantly, and perhaps the key area to focus in, is around reducing inequalities with groups. So I have a huge passion around special education needs, making sure those children are well supported as they transition to adulthood. Thank you, Matthew.
So the priority, as John has just described, is split into two. So getting ready for education and leaving education well. The bit that I'm leading on getting ready for education, and if you, as your committee members, all have access to the action plan, there are 10 deliverables that we have started to describe, 6 of which are focused on those early years support, knowing that early years support is a key determinant of how a child is then going to go into school, but also then flourish and go into adulthood. So I guess what we're looking at today with members of the committee is we, as Susan said, we've co-produced this strategy. I think it's the right thing. It's a mixture of universal and targeted interventions, all based on evidence base, which is specified in chapter 1. And Nick, chapter 1 is about children, just to go back to your early point, right at the beginning. And secondly, it then has these specifics of what we want to do. We want to just check out that, you know, people are happy with it, because all of them are cross-organizational and all of them are cross-sectorial. So they will need the council responsibilities, they will need the district responsibilities, they will need the NHS, they will need the broader voluntary sector elements to be involved in this, as well as local community. So if you look at your action plan, for instance, let's just pick on a few of them, promote the start of life offer through health and community settings. That has everything to do with the broad work we do across maternity providers, general practice, health visitors, community venues. Absolutely mission critical that we get that right around immunisation, about development and checking development delay early. I think the other area I just want to talk about, infant feeding support, absolutely crucial that we get that right. And we would be obviously using, as we already do, as a guide, the UNICEF baby friendly breastfeeding guidelines, which are really important, evidence-based, and really drive good outcomes. And then the last one, I think I would just make sure that people are aware of, which we identified really early on. And I think we have district council support, is about that issue in deliverable 6 about damp-free accommodation. Now, that's obviously been in the news quite massively in terms of the tragic death up in the northwest, but actually we know the evidence about damp respiratory on a child with asthma and then the terrible outcomes it can have. And Cambridgeshire does not have the best outcomes for respiratory outcomes for children, where we shouldn't be that pleased with that. Therefore, housing, even though this will be a massive challenge, housing is a key determinant in making sure in the environment that happens. The other 4 are very much focused on what John does with his colleagues in schools, to really be focused on how we can support children through that approach.
Thank you. I'll just end by saying what you see in the deliverables is the conditions to support good outcomes. We have fantastic schools and education offer across Cambridgeshire and Peterborough. Environment, support, if we can get these factors right, that is the greatest tool of school improvement that I have. So, I fully commend the report to you, and we very much welcome any questions or comments on the proposal actions that we're intending to take.
Thanks. Jyoti, do you want to, I think
perhaps if we run through all the presentations and then take the questions at the end. So the next one is tackling obesity, and Louis is going to kick us off. There we go, Louis, it's up now.
Thanks, Jyoti. So I think we have spent a lot of time previously talking about the case for change and why we need to focus on this as a priority. So not going to go through the evidence here again, but I'm going to focus on the kind of the key targets that we want to aim for in this program. And then I'm going to hand over to Jyoti just to talk through the high-level actions, and then happy to take any questions. So if we go to the next slide, from a childhood obesity point of view, this chart basically indicates the current prevalence for unhealthy weight, so overweight or obese children. And the targets that we want to aim for is to reduce childhood overweight or obesity to pre-pandemic levels by 2026. So
sorry, could I ask a favor? Can you get is it possible to get we can't. All right, fine. Thought I'd ask.
if there's a minimize button, I think on the side, it's not working. Okay, it's okay. I mean, the targets are at least very clear on the side. So reduce to pre-pandemic levels by 2026, achieve a further 5% decrease in childhood overweight and obesity by 2030, and then to have 20% more children meeting the physical activity recommendation by 2030, which is comparable to the highest rates in England. And then, of course, as an overarching thing, as we've talked about, is to reduce the inequalities in overweight and obesity in children. And then on adults, there's obviously, as we've talked about before, less information available on adult weight and obesity. But again, what we want to aim for is to reduce to the pre-COVID levels by 2030, and to achieve a 10% increase in the number of adults who undertake 150 minutes of physical activity per week by 2030. And then again, as an overarching aim, to reduce the inequalities in overweight and obesity. I'll hand over to Jyoti now just to talk through some of the key actions.
Thank you. So we're taking a pragmatic approach with a mix of universal, and you've heard me talk when I've presented my annual report about the importance of universal measures, particularly in reducing inequalities, but also complemented with some targeted measures. We recognise that you need a mix of strategies that tackle the environment, but also reach individuals, and the measures that we've set out really do have a mix of those. So starting with the approach in early years and schools-based interventions, we want to address both the internal and external food environments. So we're starting with a survey of schools to see what food kids are exposed to at the moment, but we also want to have fast food free zones around schools and reducing local advertising, and then working with school food providers and schools to improve both the quality and reduce the calorific exposure to food in schools. And then physical activity, of course, is the other side of the coin, absolutely embedding that into the school day through approaches like the daily mile, but also increasing active travel and supporting families to travel actively to schools. So, for example, having car exclusion zones around drop-off, pick-up times. And then addressing the financial and cultural and emotional issues that result in people feeling that they can't exercise or are consuming too much. And our key lever for this is to really understand, why people behave in the way they do, what would motivate them to change, and what the barriers are to change, so that we can then design interventions around that, coupled with our understanding of the evidence base of what works to support people to make those changes. And then the final part of the approach in the first year is identification of obesity through primary care. So systematic identification of people who are overweight, and then offering them appropriate either behavioural or clinical interventions as required. So I think I've pretty much covered that. So the first year is going to focus on schools, focus on the behavioural insights and understanding the evidence, and what we learn from this year's work will also inform what we do next year. This is absolutely building on a number of interventions that we've already got in place in terms of weight management. So this is adding to, we're going to carry on with our business as usual. This will absolutely strengthen what we're doing. So there are 5 key deliverables that we've identified. One, to establish a delivery oversight vehicle, and that will bring all of the key partners together to really drive forward the changes that we want to see. Behavioural insights gathering is another key rung, which will give us further insight in which we can then develop our interventions based on knowledge of what is making people behave in the way they do and what would support them to change their behaviours. And then addressing the food environment around schools, both within schools and external to schools, and supporting children to be active within schools and to get to and from school in an active way. and then further developing our interventions based on the insight that we get from our behavioural insights and our evidence reviews. Thank you. So if I could hand over to Liz next. Yeah. Yes.
Thank you, Chair. So our priority is housing and skills, and I'm presenting on the housing element of it, and my colleague Val is presenting on the skills bit. So in terms of housing, I think there are some really long-term issues which are take a kind of systematic approach across largely planning authorities, actually, in terms of things like design of housing, design of space around housing, and so on. And those form part of our action plan. And then there are some short-term issues that require much broader system collaboration. And I guess that's why I made the earlier comment about what we mean by the system. So we held a housing and health summit on the 10th of February, and we had 53 attendees from across Cambridgeshire and Peterborough. And attending the event with small parts of what I call the system, which is the ICB, GP practices, local health trusts, ambulance trusts, social prescribers, local authority, county, city and district representatives, children in social care, housing, planning, environmental health, communities teams, home improvement agencies, housing associations, police, fire, and the voluntary sector. So it's a bigger group that we're working with in terms of housing. But we felt it was really important to involve all of that group and to get buy-in from the group. So we're going a little bit more slowly, potentially, than some of the other priorities. But that's because if we want real change to happen, people need to kind of own the change and believe in the change and be part of the change. So we have plans for a follow-up summit in 6 to 9 months to review our progress. We came up with an action plan, which I think has been circulated. But part of I think the real benefit of that summit was people reconnecting, or maybe even connecting. I was going to say reconnecting since COVID, but actually some people met each other for the first time. Some of my colleagues from districts met social prescribers who, you know, I mean, there was a queue for the social prescriber who attended to try to find out how can our services that we provide either in the voluntary sector or districts be prescribed by social prescribers, because there is a wealth of opportunity out there, particularly around housing and skills, but broader than that. And so I think it was a really positive first step, and you can see our priorities and the emerging action plan in the documents. Thank you.
Val, do you want to do the? Yeah, okay.
Just trying to minimize, get rid of that bit, Fiona. Right, okay. Yeah, I'm Val Thomas. I'm Deputy Director of Public Health in Cambridge, working across Peterborough, and I'm here for Bliss Miller, who is the Director of Skills at the Combined Authority. She was unable to make it today. The other part of the poverty priority has this focus upon employment, skills and health. And there are some key themes in it. The first one is the barriers that people who have poor health or disability experiencing in getting into employment and maintaining employment. The wider issue is good work, so work that has a decent wage, has good contracts, and the working environment itself is conducive to health. And I think it's very well established in terms of there's a solid evidence base for work is incredibly conducive to health. Our working age population is the largest population group and an area certainly of focus. So our long-term outcomes are very much, I think colleagues talked about children in poverty. and then looking at basically how can we keep more people in work. But the more specific ones, looking at skills and providing opportunities for people to perhaps have a career change. And then those long-term health conditions or disabilities, it might be caring responsibilities, so that they're not barriers to being in employment. And then the workplace environment itself, how can that be conducive to good health? Oops. Just a couple of figures here. This just picks up on the sort of health conditions, and the main ones are mental health and musculoskeletal. But I think probably the significant factor there is, for instance, in the 18 to 14-year-olds, the numbers that have a health conditioning that is a barrier to work, and secondly, then the older age groups. And then the other side of the coin, the new starters on universal credit and that upturn that we've seen. In terms of the action planning, you'll have seen the more developed action plan, but I think what we're aiming for is that something that's realistic and to some degree pragmatic. It's a huge agenda, and as with all the priorities, it demands a very system-wide approach. We've had a long-standing, well, let's say nearly 2 years, about 18 months, 2 years, oversight group, which was born prior to this becoming a priority for this strategy. And that group is very much focused on supporting planning, prioritizing, and so forth. The action plan focuses on the next 2 years, well, this year, almost 23-24 and 24-25. And the first year is very much focused on research evidence that we can implement and inform our implementation of actions in the following year and subsequent years. So in summary, I think there are two key areas: better integration across the whole system, and how can we support employers and employees to improve employment outcomes. And this first sort of high-level diagram captures the key areas, very much looking at pathways that cut across health, social care, and employment. We are looking at how we can develop a collaborative model for working across those sectors, but also training providers and Department of Work and Pensions. And there's some other trailblazer pilots from around the country which we'd like to look at developing locally, and also having a very visual idea of what is happening in our different areas in terms of the types of services that we could co-locate. There's lots of opportunities where emerging, certainly through a hub development, where we could co-locate a lot of these service, health, social care, DWP, and other employment services, which could really ensure that the pathway into employment, which needs so many, because of the complexity, very often needs so many parts of the system to be integrated. And lastly, we want to do a digital map of local employment patterns, which essentially would shape those developments. And then the key other area of support, and these actions here were based on quite a lot of consultation we've done with employers and lived experience of employees. And there was a persistent demand for more information and advice. There was a lot of discussion around the role of the public sector as anchor institutions, very large-scale employers, and how they can influence skills development, terms and conditions, and so forth. And looking at what we have in the system in terms of training, which could support HR personnel and occupational health, for example, to help employers improve what their offer is to their employees. And with that, I think.
Thank you. And then we've got Kathy joining online.
Hi, everybody. So I'm Kathy Hartley, a consultant in public health responsible for population mental health. And I'm going to talk through the mental health part of the health and wellbeing ICS priority. This is on behalf of Vicky Evans and Steve Legout, who are the SROs for this priority. So as you are probably very well aware, mental health has, we are increasingly concerned about the mental health of the population after the pandemic, and particularly for children and young people, with increasing referrals and waiting times to have increased also for services, for children and young people to access services in mental well-being. So the need has increased. So this work is really around what we can do more upstream around preventing mental health problems arising and supporting those, the population with mental well-being in general terms. And it builds on work that was already sort of underway in a public mental health strategy, and also what we're doing currently with the mental health needs assessment for the system, so system-wide work. And that looks chapter by chapter at the various aspects of mental health across the whole pathway of care. So we're looking at children and young people, we're looking at perinatal mental health, we're looking at the wider determinants of health, and we're looking at the burden of disease. So this is a 2-year project that's ongoing at the moment. So the strategy, the priority within this, the health and wellbeing strategy, was, as I said, based on the population mental health strategy. And it was informed by a lot of consultation and surveys as well with the public, and also a lot of stakeholder engagement. And in fact, the action plan has been formed as a result of a task force meeting we had a few weeks ago, where we had about 45 representatives come from across the whole board, people working in mental health and community sector organisations. And we have sort of tried to think of what outcomes, long-term population outcomes we'd like to achieve in mental well-being. And we broke this down into outcomes for children and young people and also for adults. So for children and young people, we'd like, we have a school survey that looks at child well-being. And so we'd like to increase the mental well-being, the scores of the numbers of children scoring high on the mental well-being score. We'd also like to increase the proportion of adults who report a good or very good score in their life being worthwhile through their census information. We'd also like to reduce the proportion of children and young people who need to be referred into mental health services. And what has really come back to us time and time again is people still don't understand or know what is the information required to help themselves with their mental well-being or to access services. So we'd like to increase understanding of what people can do and what choices they can make to best support themselves and the people they care about in terms of mental well-being. So we basically have split up our actions into themes based on sort of how we can improve mental wellbeing learning from the feedback we've had from surveys and people and the task force. So there are three main themes. The first is around communications, information, and resources, and this is across the whole life course. So we want to increase people's understanding of what they can do and the choices they have to best support themselves. And to do this, and also to inform them about how to the best well-being that they can have for themselves. And of course, there's massive crossover in the other priorities as well that you've just heard about. So all of the actions in the other 3 priorities will actually work towards better mental well-being. But the priority around communication and information is we're going to have a task and finish group that already looks at the communications and information that's available, and we will reassess where the gaps are and the needs are for putting out better quality information and campaigns. And so we'll review what is available for the whole pathway and action plan various campaigns and mechanisms to communicate better information across the whole board. And linked to that, we would like to look at the idea, I think Val mentioned it, of extending, looking at the warm hubs and looking at how we can merge those into some kind of well-being hub in the future that includes the sort of wider determinants of health and supports better information for people about how to be mentally well. In addition, we'll also revamp the Keep Your Head website, which is the go-to resource for mental wellbeing in Cambridgeshire and Peterborough, and bring it much more up to date. Our second theme is around motivation. So a lot of feedback we got, particularly from people struggling with mental health, is that they often don't have the motivation to engage with the things they understand are good for them or the services. So this is a two-way aspect. First of all, we'd like to understand what motivates people. So we know things like peer support can work for some people in some particular groups, like drug alcohol users who have mental health problems. We might look at community navigators, and I know there's a lot of this work going on already across Cambridgeshire and Peterborough, but how we best support people who have maybe been in touch with social prescribing to then actually make the changes, that is the behaviour changes that we're looking for, and life coaching skills. The other aspect is also how we make services and treatments and more accessible to people, so that they don't feel that there is a barrier in accessing them. So it's how can we make them more welcoming, more inclusive, to engage with people and motivate them to actually do the good that we know that will support them with their mental well-being. So again, we will look at review the evidence and the gaps in the information about what is available and what works best, and we will start to look at implementing particular areas around motivation.
Kathy, I think we probably need to stop there and allow time for questions.
The rest of the actions are in the action plan.
Thank you.
Thank you very much. And for all the presentations, like I said in the beginning, it's really a challenge, isn't it, to have such important topics brought to us for a compressed afternoon. So I wanted to suggest that we just, if we could take questions all together and just to capture the key concerns. And then for your reassurance, I think what we've decided to do, we hope to do going forward, is to take 2 priorities for each meetings to be able to give us a chance to focus a bit more. But thank you so much, all of you. And does anyone wish to comment or? No panic then. Okay. Julie and Nick and Lynn. Yeah.
Thank you very much, everybody. Thanks very much for such a comprehensive overview of what's going on. Really interesting. I do have a couple of questions about how things link together. I think the priorities look right. They seem, they've certainly been well researched, and I know we've been talked about it quite a lot. But for me, there's a couple of strands I think that do link together, and I'd like to understand how we're going to move forward with that. We all know that we've got workforce issues. There were workforce issues with every single organisation that's part and parcel of the system. And when I think about, really great that the government has said they're going to increase the number of childcare providers, but we know that independent childcare providers in Cambridgeshire and Peterborough are closing, not daily, but they're closing on a regular basis because they can't get the staff. You get paid more by working in Tesco or Lidl than you do in any kind of childcare setting, unless it's a childcare setting that actually is run by the local authority. How are we going to be able to ensure that our children have the best start in life and have proper childcare if we haven't got the workforce to be able to do that? And I would like to see that actually at some kind of demonstration about how that's going to work across with our workforce plan. I'll let you answer that, but I do have another question that I can go on to later.
Thank you. I think you made a really salient point there. It is a big challenge. We are competing with supermarkets for key jobs in education, so teaching assistants, nursery nurses and others. The good news is there is additional funding coming, so we'll be able to be more competitive around pay. It's probably not enough, so we need to work on that. We have plans in both local authorities around workforce, including training, support, doing more work in schools around information, advice and guidance about the profession of early years and supporting that. So very minded of that. We are waiting for the detail of the government changes because that will require workforce change, and we will bring papers probably through the Children and Young People's Committee and through the Children's and Education Scrutiny Committee, but it's on our list and we're working on it.
Thank you. Can I ask my second question? Is that
yes,
okay?
I'll just say, unfortunately, we have to be quite disciplined because we're a bit over time. We did lose time in the beginning, not our fault, but I think we will try and be succinct and try to finish up in the next sort of 5 minutes because we're 5 minutes over.
So I've got one question about skills, if that's okay. Well, actually, it is actually about the employment piece that you actually very eloquently brought together. You talk about the pathway into employment. Now, we know there's a lot of evidence base that says pathway into employment actually can be via volunteering, but there's no mention of volunteering whatsoever in the strategy. And for me, it's a key pillar of how we get people who have not been employed or are unhappy in their current employment into the next bit of their career. And I'd like to see some acknowledgement of that, if that's at all possible.
I think that's a very fair comment, Julie. I think it's probably there, but I think it needs to be more visible.
Thanks. I've had a good friendly nudge saying, let's give it a few extra minutes. Nick.
Yeah, thank you. First of all, absolutely 4 priorities, fully behind them. It's a question really to those who are leading on priority 2 and 3, particularly. 2 is to create an environment that gives people the opportunity to be healthy as can be, and 3 being reducing poverty through better housing, employment and skills. I obviously acknowledge with regard to the skills agenda and in the past housing, my own organisation, the Combined Authority, has a role to play here. But for the leaders of those kind of strands, what I'm particularly keen to understand is where does the statutory responsibility for transport lead? Because we can design the best services in the world, but if people can't get to them, I mean, I know we are obviously pushing for more to be delivered in the community, and that should be echoed. But even if we're delivering in the community, those providers, be they in social care or health, they still need to be able to get around in a timely manner without congestion, you know, or in the terms of kind of how we got reliable access to transport in terms of affordable transport between opportunities of education or indeed work. So it's sort of this question back to those 2 leaders where you focused on that. Have you considered the aspect of transport and indeed, has there been, our organisation have we reported in to the LTCP, which is the Local Transport and Connectivity Plan, currently being put together by my organisation to make sure that this is all linking up, because we can design the best things in the world, but if you can't actually get to them, it's not going to be any good.
I'm not, sorry, are you going to answer that one?
Only to say that as part of the consultation process, that came out loud and clear amongst the lived experience that we could facilitate, develop a pathway, but for some, transport is a challenge.
I think I'd just like to follow up Nick's question on responding to the formality of, and it's one of my questions too, the whole question of access and travel comes through all of the priorities really. And has there been a representation made, or can there be, can we articulate this more strongly as a system, I suppose? And I'm sure there will be other opportunities to do that.
Just to come back on that, I mean, I can check within my own organisation, has it been done? Have we received representation from the Health and Wellbeing Board and ICB? It's just to put the point in where you're creating an environment that gives people the opportunity to be healthy as they can be. Obviously, that's active transport. That is kind of getting people out of their cars, cycle lanes. That's important. And I just need to be clear that my organisation is doing it, but at the same time, I know we're a new organisation, but let's get it right from the start.
Thank you, Jyoti.
Thank you. I'll take a couple of points that have been raised. So the cross linkages, we have made attempts to have workshops to look at the cross linkages, but they were always a bit abstract because we didn't have the plans. But now that we've got the plans, we can have more meaningful conversations about common themes. So workforce transport might be two of them, interdependencies and linkages, and how we may all need to engage with the same partners and how we do that in a coordinated way. So I think now that we've got the action plan, we will move to a workshop that addresses some of those cross linkages. And I might take your offer, Nick, as an invitation for us to come then to you with the issues around transport. We are absolutely, I know in the healthy living one, looking at active travel and looking at how we can restrict cars around schools at drop off and pick up time so that it's a more inviting environment for walking and cycling. So it's absolutely part of our thinking, but I think that we need to knit it up with you a bit more. Yeah.
This is the reason Richard's in the room. I don't know if you want to add anything, Richard.
Yeah, sure. No, thank you. Yeah, I mean, absolutely. We have got a health strand running through the LTCP. The LTCP is in draft form at the moment, so I think it would be timely, because that health strand, you might not agree with that health strand, how it is emerging. So there could be some iteration between us to make sure that we join it up and the strategies are working together collectively. I don't want to create a lot more work, but a similar thing could probably be said about the economy and the links between health and the economy and productivity and so on. I know that in all the integrated care system agenda now, there is a kind of an economic growth linkage that needs to be developed. So again, that needs to be iterated probably between the organisations. And just while I've got the microphone, one of the things I'd just like to say is, I think the priorities and the action plans that link to them are really excellent. And I'm also taken by the fact that this document has got my favourite diagram in it, which is the foresight diagram on complexity. It was an absolute massive piece of work back in 2007. And I really love the way that engine comes together at the very centre of it. And I'm a very great advocate of that. And I would really like to see that used possibly more widely, but I know it was a very intensive piece of work. But given most of the conversation so far has been about the linkages between things, it just strikes me that somewhere in the strategy, there could be a high level and perhaps some sub-level key diagrams that actually do draw out the interrelationships and the interdependencies in a quite a clear way, because I think that's a really good way of communicating what is a very complicated set of papers to actually plow through. So I think in terms of communicating these key messages, having a big key diagram with perhaps some sub-diagrams would really possibly add value. It's just an observation.
Thank you for that. If I may just insert, my own question was going to be, how are we going to convey a vision for societal change, really, because we are talking about behavior. And so in addition to the diagram for us, I think we need to think about basic communication with the public. But I'll look at the diagram first to get guidance. Stuart and then Lynn, thanks.
First, the plans are great. My point starts with meanwhile, because there are clearly people that we've consistently referred to, those people who are on waiting lists. And so it's about plans about managing those people, the meanwhile, while we get these things moving. Then obviously that we are concerned about how people are managed while they're actually waiting. But let me just home in on one particular area, because Jonathan's joined us today. It does strike me with young people's mental health that but while people are waiting, a lot of the responsibility is falling on schools and teachers. And I just wondered whether Jonathan has a view about the support that's being offered in that particular area, as we've spoken a lot about young people today.
Yeah, I'm pleased to say one of the deliverables is setting up a new board that will involve school leadership to make sure the offer out there is coordinated and we're aware of the gaps and how we can support and develop. And I think that's a real step forward to be more demanding of what we need in schools and help shape the offer. So that's one of the deliverables as part of the priority one. Thank you.
Lynn?
Thank you. Yes, I mean, it's obvious from looking at all of these 4 priorities, which I think are very good and very important, because a lot of them rely upon looking at the child first and eventually moving through to adulthood, which we've all done around this table. So I think obviously where Peterborough is concerned, it's very important, because you only got to look at the figures to see that. But I'm a little bit concerned that we in Peterborough are developing our strategies. I'm sure that Cambridgeshire and the other district councils are developing their strategies for all of these things. And what we mustn't do, because we're supposed to be an integrated care system, is work in silos. Things have got to be brought together, and it is this joining up that I think you were talking about. In particular, and the linkages. I think that will make all the difference in the world as to whether we actually do anything at the end of this other than talk and other than write documents. So that's the principal thing I wanted to say. And I wanted to say, I might say you're going to hear that again when it comes to the forward plan, because it's so important that we all are equal partners in this, I think is the way to put it. And I don't think it's happened before, and I think it's hugely important.
Jyoti.
So I would say that that the health and wellbeing strategy is absolutely embedded into the Peterborough strategy, and I lead on the priority where that sits. So it's there and it's real, and part of that will be about bringing in broader council resources to support us on delivering the health and wellbeing objective. So it's there, and we're working on getting it into the Cambridgeshire one as well. Elements of it are there. I think my team, Val and Emmeline, have tried to get this embedded into the North and South Place ABUs. I think they're at various stages of development and embedding them, but they're things that both Val and Emmeline are actively pushing to make real as part of their plans as well.
Great, thanks. John.
Thanks, Susan. Just, 2 points really. One, thank you very much to all of the SROs and all of the people working on it for the sort of huge amount of effort that they've been putting in. And I think it would be good, as you say, Susan, in the future, if we have the chance to focus and create a bit more of a dialogue with the SROs on the team, and therefore perhaps doing less of them, but possibly also in a slightly less committee-like structure. The second point, I suppose, is that it's something for us to reflect on, but I'd sort of quite like to invite the SROs to reflect on, not to respond to today, really, is that I suppose, one of the tests for us is, are there things that can only happen as a result of not just us coming together, but this structure, being established to bring the partners together? Where can we actually add some real and distinctive value to things that would happen, that wouldn't happen otherwise? And I suppose we should reflect on that ourselves, but it would be good also, I think, to get the feedback from SROs about, well, and some of that will be bound to be about, well, you need to take this back into your own organizations and socialize it and make sure it has salience there. But it'd be quite good for, I think, for some feedback to sort of crystallize that, for an ask of us actually about what it is that we need to do in order to sort of help take all of these forward.
Thank you. And sorry?
It's going to respond to that point, really. I think it's one of the themes that we want to develop at our next development day. How do we want anchor institution charters, for example, or what's the minimum commitment that each organisation will bring to these priorities?
John Howard.
Thank you, Chair. Thank you. I think it's been a really interesting session. I think it's brought life into the 4 priorities to see the deliverables. I think you can start to see some real life going into what we're trying to achieve. I think the interesting thing I see looking at this is how it really does cross so many departments, and many departments that will probably never sit at this table. Like I'm looking at it from the council portfolio side, and already seeing housing and communities are absolutely, top in trying to help us to deliver these priorities. I think that's something we'll have to think about outside the meeting, is how we bring the other departments who can drive so much into this, into the arena and into the discussions. But yeah, really good to see.
Thank you. Chetty, did you want to say any final?
No, I think it's all been said, really. It's all full steam ahead now in terms of delivery.
Okay, well, we will look forward to coming back, I think, at our next formal meeting with some of this. Okay, so the board is asked to approve the content of the 4 strategic priorities and their initial action plans. And it is anticipated that the action plans will develop and evolve over the course of the year, and updates will be provided to the board. So I'm assuming everyone's happy to take that forward. Yep. Thank you. Thank you very much. Okay, well, I think Kit, you're on now for a couple of items. And I'm sorry we're there's not quite as much time as we hoped, but could I invite you to take us through item 5, the joint forward plan. And then just thinking we've had a proposed additional recommendation, which I think I might just read out now. Just so you can note it is we need to determine the mechanism for finalizing the Health and Wellbeing Board and ICP's input and discharge of duties in signing off the plan. So we'll need to agree today what those steps will be. And so that recommendation might change after we decide what that is. Thank you.
Thank you, Chair, and noted around the limited time on this. But what I want to give colleagues around this table and online is assurance that this is the first time that we are bringing this joint forward plan. There's plenty of time for further iteration. So it's the introduction of this item. So firstly, apologies about the volume of documentation. We are trying, as always, to be as transparent as possible about where we are up to, and it's a moving feast in terms of its development. And this information is also being shared more widely within the system. So just to pick up for the previous item, this is about how we translate strategy and our overarching aims as an integrated care system into delivery, and the delivery from health and its broadest remit, not just the NHS organisations and the Integrated Care Board, but those partners as well around that table. And there's some very clear requirements for us in this space, which are set out through national guidance and is referred to in the document. So just briefly, what we have done is set out in terms of the way we've taken this approach. We've worked with system partners, and it's been in development since October, November, December last year. We have aligned ourselves to the 4 principles that the integrated care system works to around thinking local, keeping it simple, doing this work together, and then proving it, making sure it's delivery focused. And these are meaningful plans that we can hold ourselves and be held to account for. To that end, we will have clear delivery plans. We also committed to, within this space, about engaging with our people and our communities. And earlier this week, we launched the phase 2 of our Let's Talk campaign around the specific areas of the Joint Forward Plan. That can be found on the Integrated Care System's website. And we've also written out to MPs and to local stakeholders, as well as we'll be engaging further with Health Watch and our people and communities to gather really detailed feedback about the things that are meaningful for them and how we come to the next version of this joint forward plan that's taken into account. So just picking up Kenny's point around some of the diagrams, we hope that this is brought to life through the document in terms of the diagrams and the relationship between the integrated care strategy and the joint forward plan, and also the next item around the estate strategy as well. So there is a clear requirement for the Health and Wellbeing Board and the Integrated Care Partnership to provide feedback and input into the joint forward plan. There's a requirement to advise whether it does take proper account of the strategy. And in the final version, we do need to include a statement that agrees with that. But I do want to give assurance that there's plenty of time to comment. So what you'll see in the pack are 3 sets of documents. Firstly is a summary of the content that is hopefully helps as a high level input of the various sections. The second is an example of the delivery plan, and we are circulating all of those delivery plans within the wider system at this point in time. So there's very clear scope of the remit of what's being delivered, who the senior responsible officer is, who the executive leaders in the ICB, and which group in the system has oversight of all that. And against each of those, we'll measure those milestones, much as we've talked about within the integrated care strategy. And then finally, at the end is the current draft. And I do need to reiterate, it is a draft. It is being submitted to Region, as we are required to do next week, to gather their feedback and comments, and we'll have that returned to us in early April. And we are also now been discussing it in various system groups where health and other colleagues are present. And we're asking for exactly the same challenge we've given here around the integrated care strategy, around that check and challenge, the interdependencies and the cross-reading across all areas. And so I would welcome any comments from this board on where we've got to, and also around how we might develop that further, and some check and challenge in a future development session for this group.
Thank you very much, Kit. And I should just add that we had the benefit of an informal session a week or so ago to have the very first look. For me, I didn't know there was such a thing as a joint forward plan. It is a very important set of requirements and needs to be taken seriously and meaningfully responded to. We'll maybe take a couple of questions here and then think about how we might have the chance to reconvene informally or formally ahead of the required submission date, which I believe is June the 30th by the ICB. So we'll start with some questions, and then we'll move to consider how we're going to look at it in a more evolved form. I see Richard and Lynn. Thanks.
Well, first of all, thank you. And I have some deep sympathy with Kit and her colleagues that the requirements that are put on them are that we have to have these large numbers of pages, and they have to fulfill very strict criteria for the public, for citizens and for patients. These pages, I think, will be confusing. That we've got a joint needs assessment, we've got a health and wellbeing strategy, we now have a 5-year plan, I praise the work that they've been doing, you've been doing on Let's Talk to try and make this meaningful to people. But I do think that we have a joint challenge for that to be the case. My first reading of the document is that it faithfully reflects the work that we've been doing together in the last year or so in terms of the strategy, which is great to see. But I wonder, and those of us that come from local government are representing the citizens, what is actually different in the I don't think anyone was silencing me there. What is actually different in practice, from what was there before? And I think it's probably incumbent on all of us to try and understand that, because we're about trying to change things to be better. And there's always been good intentions around these areas, and made in good faith, let's be honest. So let's try and see how this new system approach and the approach that we're choosing to be more neighbourhood and person-centred, to see where we're actually making a difference. And I don't expect a detailed answer on that today, but I think it's our joint mission to try and to be able to articulate that answer. In terms of your additional recommendation, I strongly support any efforts for us to have more informal discussions to look at this in detail rather than try to deal with this only in short formal discussions, because I think dialogue is needed rather than formal question and answer. I would, and we had a very interesting development session recently, I would concur with the points particularly made by Lynn earlier. I think there is an opportunity here really to prove that we're doing things jointly as a system, and it's not just those of us who are the partners sitting on the outside commenting, but the steamroller just drives on. Achieving that is much more easily said than done, I'd be the first to accept, but I think all of us need to really explore that. And the feedback I've also given about Let's Talk, there's a bit of I have a bit of a feeling, and I may well be wrong, that the Let's Talk is like, well, we've got this strategy and then we'll have this consultation, and it's not being done as a system, it's being done by the board as a board and really by the NHS. And I would hope that the CPCA, our friends at Peterborough and ourselves could be really active partners in the communications and engagement element, and that we're doing this together rather than comment on it and it's done by the ICB as a separate entity. And so there is time for us to do that actually between now and June. And so I really ask for there to be an opportunity to explore that. As ever, though, there's a hell of a lot of work behind this, and we should say thank you very much.
Thanks very much. Lynn, did you want to ask a question?
Yes, well, I wanted to comment as much as anything. And in fact, I was going to comment in much the same way as Richard. And may I tell everybody, we didn't get our heads together on this at all. Just because when I looked at this forward plan, I hadn't realised there was one either, that you obviously been having one in health for years. And I didn't know that. But I just thought to myself, well, this is obviously a health plan. It's not a lot to do with what we are doing in the local authorities and how we're going to deliver and where our estates come into it. And think that's for the next question, of course, as well. And I just think it needs to be more integrated. And it's that aspect, and it's the only aspect, because I think it's brilliant. There's been so much work going into it that I think it's so important. But we want to be able to go out there and say, this is our integrated plan with health and the local authorities and the volunteers, etc. And if we can't do that, people will just think, oh, they're just talking again. So I know it's down to delivery, but the plan itself, it needs to show it somehow. The words need to change. Thank you.
Kit, would you like to respond?
So I think just picking up both the feedback. So thank you for the acknowledgement of the work. It's not me, it's my team and the people in the system. It's been a Herculean effort, and I'm sure they enjoy writing 50-page strategies. But you're right, it is about the delivery, and it is about the way in which we all commit to that delivery. So health isn't just the health organisations, it's broader than that. That's what we've committed to. And that's the challenge we've put back through system groups. And I really welcome the challenge about language and how it feels a little health focused. We have asked local authority colleagues to read it through that lens and how we broaden that language out so it does feel more inclusive and people really understand and engage with it. And the final point, really welcome about the active partnership around doing it together with engagement. It's really important. We had 2,500 responses for the first campaign around the strategy. If we can at least meet that or increase that, that will be enormously helpful. Because it is about the public seeing that we are speaking as one voice and not just as health. And the more we do that and iterate that, I think it's more meaningful.
John.
Yeah, and just reflecting on particularly contributions from Lynn and Richard, which I think are really helpful and some really good tests, I think, for all of this. This plan, as has been rightly perceived, sits sort of slightly uneasily between our shared integrated care strategy and health and wellbeing strategy, and also the requirement that the NHS places on the ICB to be the steward of the NHS in Cambridgeshire and Peterborough. And I guess what we're trying to do is put front and central the 4 priorities that we spent the last sort of 45 minutes talking about, as being at the heart. The ICB must show itself to be capable of making its contribution to delivering to that wider partnership goal. So that's the sort of foundation stone. But it is also true that there's a lot of things that we are required to do, through an NHS lens as well. And that's sort of, I think, the challenge of sort of bringing those two together. But the ICB is a partnership body, and therefore it's absolutely right that we try and do that collaboratively. And if to that end, Susan, the amendment you're proposing is that we spend some more time, I think, informally and in a session that allows dialogue and the sort of nature of the conversation that Richard was talking about, I think that would be a helpful thing to do if we can get that, and then allow the ICB to do what it has to do at the end of June.
Sorry.
Thank you. Excuse me. I think just a point I'd like to make on behalf of the Commissioner and probably the constabulary that aren't here is the point about transport being a cross-cutting theme. I suppose there's also a cross-cutting population theme with most of what's in here around offenders, because whilst it's not a large population, it does engage pretty much every single strand in this plan in terms of housing, skills, employment. There's substantial drug dependency. There's significant mental health issues in that population. So I think the strategy is great. I think the development of the plan is good. And by definition, you have to kind of silo that a little bit in order to make it sensible and readable and understandable and parcel up pieces of work for people to do. The problem is you've then got a small cohort that sits in every single element that doesn't necessarily carry a lot of weight for each piece of that plan. So it's just really a comment to say, can we, in development of the delivery plans, because there isn't an offender delivery plan, can we look at how we can factor that small population that is engaged by so much of this?
Great. Thank you. I think this is the first document in which I've seen the word prison. Actually, I haven't seen it in any of our other documents, but it is absolutely threaded through. So really appreciate that. I guess we're like there must be a movie title about the collision of universes or something. And we're definitely the colliding planets, but that's what we wanted to do. That's why we have a committee in common. So it's great to work out, get to our obstacles and find a way through. So I guess if there are no more comments or questions, I think we have the published first 3 recommendations, and I think the 4th recommendation would be, and I'm going to ask one of the officers to please craft the words needed, but for our committee in common to convene informally in person in June at the right moment to be able to receive the more advanced stage of this paper, but with time to feedback for the publication of the ICB paper on the 30th of June. And therefore that would necessitate delegating the sign off to the chairs. Does that make sense? Yeah. Okay. Is everyone happy with that? And you promised to come along. Okay. So I'll move now to the recommendations. The board is invited to note the report around the ICS Joint Forward Plan, note the system approach to developing the Joint Forward Plan, support the ongoing development of the Joint Forward Plan over the next few months, consider its alignment with the broader strategic aims and aspirations as set out in the Health and Wellbeing Integrated Care Strategy, and specifically the discharge of health duties and obligations. And then the one I just said, that would be D. Is everyone happy to accept that? Yes, okay. Thank you very much. Great. In that case, we will move on again to Kit, who is going to take us through item 6, the Cambridgeshire and Peterborough Estate Strategy.
Thank you, Chair. So this has a clear read across if you think about the integrated care strategy, moving to the joint forward plan. And in the joint forward plan on page 152 of that plan, there is a section on estates and infrastructure. And what we, of course, need to do is make sure that there's some detailed programme of work and strategy surrounding that, and also a work plan, which is what this estate strategy sets out. So this work has been underway across the whole of the system. When I talk about the system, I mean health and care. Through the estates group to develop an integrated estate strategy with support from NHS Property Services, who are one of our strategic partners. We've gathered information from a range of organisations. We've also been looking at primary care organisations, and also held workshops and gathered feedback, of which we have a wealth, and particularly from primary care, thank you, given some of the challenges around existing system estates. That work has informed a first draft, and I must iterate that's a first draft of the system estate strategy. We acknowledge that there are data gaps, and we are working on that. We also acknowledge this is a moving picture in terms of our current estate and where we might wish to get to. But there was comprehensive agreement from the System Estates Group and subsequently the Integrated Care Board that the plan was deemed to be sufficiently robust to inform decision making, whilst acknowledging further work is done. We have, as a result of that, enlisted additional support from NHS Property Services, who, as I say, have been an excellent strategic partner for us. We've got additional primary care planning and also further work to do on the assessment of our estate infrastructure, and also to think about our collective ambitions. And to this end, what we just want to highlight really at this stage is that we do need further socialisation of the plan. It is pretty much a health-focused plan at this point in time, with aspirations that go beyond health. But we are keen that this becomes inclusive of the wider estate for that one public estate, although recognise that is a very ambitious aim. And on that note, I think we are one of, if not the first integrated care system to have an estate strategy, and have been commended for that. So we are leading the way here, but we mustn't sit on our laurels and continue to progress this work together. Happy to take comments.
Oh, yeah, thanks. So my conflict of interest is a GP. However, I really welcome the work, because actually it's really good to kind of own the issue. And part of the issue is that primary care, general practice infrastructure is not fit for purpose in many cases. I think there's still a bit of work to be done, because I think there's still some data and stuff that people are working backwards and forwards with. But I think it's been done very collaboratively. It's been done with good intent. I guess a bit like the theme of most of this meeting and some of the comments from the councillors, a lot of the future strategy for the health and care system is going to be based on place. It's going to be based on neighbourhoods. It's going to be based on services working together. Hubs are now more and more fashionable, and sort of pockets of money are being available to address specific things. And I think kind of putting all of the papers together and all the issues together, I'd say that actually the estate strategy is really, really fundamentally important, because actually, you know, personally, I do believe that integrated neighbourhoods based around anchor organisations such as GP practices or pharmacies or whatever the chosen anchor organisation is, could well be the solution to kind of address many of the challenges that we face today.
Yeah, no, just very much to echo and support what I think Neil's just said, I think. And so I very much welcome the work that's been done. I think it's really strong. And it's good that we are leading the way, but it is a lot still to do, as you've said. Just one observation. So the main point was the point that Neil was going to make. So I endorse what you said and agree with that. Just on the linkage between estate strategy and our overall approach to
Planning gain, I think, is an area that's really important. I mean, I would criticise the NHS estate usually as not being very good at that connection, but it does seem to me that that's really fundamentally important. The second bit would be that on net zero, we should maybe link in that to a wider issue about clinical practice. I mean, for example, I think it's about 20% of the NHS carbon footprint is actually built around pharmaceuticals, of which the vast majority of that is in primary and community setting. So I think there's something about, let's not make the estate strategy just a physical thing. Net zero actually has a wider clinical application, and clinicians actually really get that and they really support that. But I think there's something about making sure that we don't just think of net zero as an estates issue. It's a much wider issue.
So I really welcome that challenge, and I'm fortunate that I also have the sustainability and net zero within my portfolio as well. We have indeed had that conversation. It isn't necessarily about buildings. It does need to link very carefully. It's about behaviour. It's about broad ownership of that. And it's not just within hospitals, it's within all community settings. There's some real challenges. There's also some massive opportunities, and I think it picks up around some of the road network links as well. What's our aspiration around that, and how do we really embed that and think about that cross-referencing? And the conversation we had earlier this week in that sustainability group is, if we read through the joint forward plan and we think about how the NHS and broader organisations will discharge their duties, we should not only see a section on sustainability, there should be green threads throughout that whole strategy. How do we make sure it's a shared responsibility, and how do we make sure that everyone feels they have ownership of that?
Thank you. I think we have Liz and then Richard.
Thank you, Chair. I have a question and two comments. My question is on page 174 of the pack, and you use a term called significantly under-doctored. But my question is, this is an estate strategy, so is the fact that PCN is significantly under-doctored relating to the estate, or is that just a piece of information?
Neil will probably be able to respond more accurately about that. They are linked because of the relationship between the way the practice owns surgery. So Neil.
So my understanding of the data is that it's making a comment on the number of doctors per 1,000 patients, for example, saying that there's a certain amount that would be the right number of doctors per 1,000 patients. And when a practice is deemed to be under-doctored, it means that they don't have that number of doctors, which could be linked to what you said, which is that there's not enough space to put the doctors. It could also be linked to the population they serve. It could be linked to the funding that they receive. So I hope that helps, but basically it probably does relate to all of those factors, but more specifically, it's a measure of the number of doctors per 1,000 patients.
Thank you. And my two comments, in terms of the strategy itself, I'm hopeful that means we can assume that we can now recommence conversations in our growth sites across Cambridgeshire. I have 3 new towns of 10,000 people each, and we would really like to get on top of the issues around what does health need. And so the problems that we're talking about today have been created because conversations weren't had however many decades ago, and we can prevent these problems from happening in these new communities if we have the conversations now. So that's my first comment. And my second comment, which Kit and I talk about all the time, is that this can't just be about the health estate. I have an entire floor of a large building that is empty, and I would put money on most non-health people around this table having the same thing, and lots of health colleagues saying we haven't got enough space, or we haven't got space in the areas where we need it. And even if we were just to do a very high level mapping exercise of our public sector estate, we might find, even if we found 1 or 2 wins, they'd be wins that would be worth it. Thank you.
Thank you. Richard.
This week. I have great sympathy with what Liz just said, and I suppose my own comment is in the same spirit. I think it's fair point to just draw to attention that Cambridgeshire County Council has got quite ambitious plans to open independent living centres, which is extra care for people, housing, but extra care for people. And we're obviously also collaborating very closely with health partners in terms of sites, and the site that we've currently got into development is at the Princess of Wales site in Ely. But it's important to say that we've stalled a bit in terms of progress. We want to go further and faster. We're prepared to commit money in our capital programme, but we can't find the sites. And I think there is a thought that the health service is going to help us in terms of jointly identifying sites, because all of that, of course, is going to help keep people independent and out of hospital and all the rest of it. So if I can just signal that we are struggling a bit in all truth to make the progress that we want to see, and if health partners can help identify redundant health facilities that might be transformed or help in any other way, we'd really appreciate
that. Julie.
Thank you. I do want to say thanks, Liz, because you picked up on a point that I wanted to make, because it's not just about NHS estates. I think this is a great strategy. I love it. Love the layout. I think it's really easy to read, lays things out in a really great way. But what I'd say is that previously we've had pieces of work that has looked at everybody's estates. We've done mapping, and we've actually also mapped where people generate to. It's not just G practices, it's other places. And when I think back to children's centres, when they did the redesign about that, they actually looked at where do families go, and actually that's how they chose which children's centres to actually amend. And I do think that's the kind of thing that we need to be thinking about doing. Where are people going to, and are there facilities there that we can utilise as a whole system, not just about health?
Could I take a question from Steve or comment?
Yeah, a comment really, just to pick up on Liz's point about the importance of trying to map as much of the capacity across all of the partner organizations that we have. And I know from some time I spent in the States, there were really good models there of capturing right across public and private sector provision what sort of capacity might be available to support residents or patients. And I guess my second observation is, I think this is as much about access strategy for residents and for citizens to be able, not just via physical estate capacity, but also by using other methods of technologies to be able to access support and services as effectively as possible. It doesn't always require physical estate to be able to do that. I think increasingly we need to invest in digital and other remote means of enabling access for citizens.
I might ask my question, following on a little bit from Liz, I think, but the question of, well, looking at the top, and we've got the district councils, we've got big buildings with lots of space in them, and we have new towns coming and the opportunity to design things well. But then we also have, existing communities, and we have a lot of talk in our respective organizations about family hub, health center, integrated hub, a lot of different language, which is about people coming to a space to get a wide variety of the things they need. There is actually an example, a very interesting example in our integrated care, our strategy, the one we adopted in December. I can never remember the name of each strategy, but it is our integrated care strategy, about a community hub where health, physical and mental health services are offered, but it's mainly a really good cafe. and there's happens to be a library there. And it's a place where you go because you enjoy walking through that door and talking to somebody, and you will probably make a friend. And so that I make that link to the mental health priority. It's not just about treatment, it's about living well in a way, and you can put the preventive word on it, but that's what it is. And so facilitating space at community level is actually really, really challenging, because communities don't have the money to build these places, and when they do, it's exceptional. So I'd be really interested to see some of that unlocked in the estates strategy. Thanks. Lynn.
Just very briefly, we have forming family hubs, of course, and we're doing them with health and with other interested parties, and they're going to be several of them across Peterborough, and I believe that Cambridgeshire will have the same sort of thing going, but they're going to be places where people go, as you rightly say, and that's the important thing, isn't it? They're expecting to get health advice there, social advice there, care advice there, anything else that you care to mention. I think is really how it's going to work, and they're going to be very important in the future. So it would be good to have those down.
Did you want to respond to any of that?
Yes, so thank you for the feedback. I think that everything that's been mentioned, we have talked about in the estates group. I think there's work to be done now about translating this strategy to an action plan, being clear about what we'll do and what we'll tackle in the years 1 to 5, and how we will do that with system partners, and thinking about that from that broader angle about what matters to communities as well as what matters to the organisations, I think is so important, and the thing that comes across around the anchor institutions. And we'll continue to report on progress around that. And Liz, I'm sure we'll have more conversation on planning as well offline.
Thank you very much. Okay, I guess we will move to the recommendations. We are invited to note the system approach to developing the strategy, support the ongoing development of the strategy and its alignment with one public estate work, and consider the broader strategic aims for estates, considering wider system intent and aspirations as set out in the Health and Wellbeing Integrated Care Strategy. Everyone happy to take that forward? Thank you. Okay, we're nearly done. We do have at item 7, I don't know if Caroline is here. It is it is a retrospective approval of the Adult Social Care Discharge Fund. Is there an officer here who would like to just present it succinctly, and then we can Judy? Oh, how about you? I will suggest then, I assume you've all read the paper, and I will ask if there are any comments. Yep, Liz.
Well, mine's a question really, and I apologise if it's not the right question for this report, but I'd like to know what were the outcomes.
As we can report that in the next meeting, none of us are aware.
Okay, we need the outcomes reported at the next meeting. Thank you. Maybe circulated before. Sorry. Oh, Mary, excuse me.
Yeah, I mean, it's a similar question, really, which I think might be helpful to go to if we are going to look at this at the next meeting, because I'm just interested to know how we're using the learning from this winter for the planning for the coming winter, and the degree to which, you know, we've got focus as a system on admission avoidance, on good sort of 2-hour rapid response, all the things that are really important to make sure the acute hospitals are only seeing those they really need to see. And I think it just might be interesting to know how we're taking that learning and how the planning is going for the coming winter, so that we're as a system all in a much better place.
Thank you, Mary. Richard and then Mike.
I agree with that last comment. There's a huge public debate about that, and it's strange that we don't talk about it. And so I think having an item like that, I would strongly welcome. I think we should all acknowledge there's a bit of artificiality about what's done by the local authorities and what's done under the aegis of the Better Care Fund. But nevertheless, that's just how money comes differently at us. But it shouldn't obscure the opportunity or prevent the opportunity for us to talk about those in principle workings, whether they come under the BCF or otherwise. The second point is this, though, it is a bit unsatisfactory, isn't it, that this is being agreed in retrospect without officer presence and to meet a timescale. This is no criticism of the officers, to meet a timescale that I think was very, very hard for them to comply, and that was true in previous years. But as you know, you and I had a planned meeting with our officer on this that got delayed, so this hasn't really been subject to member scrutiny, and I think it is important to put that on record and to ask for this to be done better in future years. But I would be the first to want to underline that I know that the timescales put on officers are almost impossible to comply with, and but I think more advanced discussion to enable proper scrutiny to take place, I think will be important in future years.
Thank you, Richard. And I think this is one of the areas that we had contemplated taking to a separate development session to get to grips with. So we might do that. And I think we would like the feedback really before July. So we'll figure out the best way of doing that. Mike.
Well, just a partial response to what Liz and others have asked, which is, first of all, I agree with the point that Richard made. I think the timing was quite challenging this year, and I think there were a few wobbles along the way, probably affecting all of us to some degree. But and so I would welcome, though, the outcomes benefit, but certainly the impression I have wearing my Addenbrooke's hat is that it made a very significant partnership activity, was very, very helpful in terms of managing complex discharges through the winter. The multi-agency working seems, from an Addenbrooke's perspective, to be much stronger than in previous times, and appreciative of the colleagues' insistence. And I think NREF had the same experience. So as far as planning through what was the most and always is the most challenging period of all, we saw that significantly better, I think, this time around than previous. And it was already good, but I think it has seen further strengthening of partnership and improvement in complex patients requiring discharge and awaiting that, and also decrease in the length of stay for those mentally ill patients and their ability to discharge. So I think that's been good. It is fragile and it is stretching of staff. So I think the idea that we need to look forward to what our planning is for next winter. We're already beginning the planning for next winter now, before this winter's even finished. So I think that's the point. So I think all the points the colleagues have made, but my sense is, from a hospital perspective, is it's been stronger this year than previous. And so thank you to colleagues.
Thank you for that. It kind of leads nicely into our next item for our forward plan, because we do need to talk about next winter before next winter. Okay, if there are no other comments, then I will read out the recommendations to read and comment on the content of this report, and to retrospectively approve the plan on the Adult Social Care Discharge Fund 2022-23, which is required to be pooled into the Better Care Fund pooled budget in order to comply with NHSE England conditions. Take it you're all happy with that. Thank you. Right, then we just have something called the forward agenda plan, which is not the forward plan we were talking about before. You'll have a copy of that in your agenda pack, and we have discussed the fact that we'd like to spend more time on the priority chapters as kind of a regular stock take, and to do that a little bit differently. And I think we have signaled that we really benefit from the informal meetings that we have between our formal meetings, and Those aren't necessarily going to be in the published document, but we need to have these conversations. And so with that, I think, oh, right. I think that's enough, actually. Thank you for attending, and I declare this meeting closed.